Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Ashok Gavaskar from Chennai, India. Dr. Ashok Sunil Gavaskar is currently the clinical lead of orthopedics and heads joint reconstruction trauma services at the Rela Institute and Medical Center in Chennai, India. He is a distinguished member of the AO Trauma Technical Commission as part of the Asia Pacific Expert Group. He is an honorable member of the International Advisory Board for Journal of American Academy of Orthopedic Surgeons. He also serves as an associate editor for the Indian Journal of Orthopedics and the European Journal of Orthopedic Surgery and Traumatology. So today it's my great honor to introduce you to Dr. Ashok Gavaskar from Chennai, India. Over to you, Ashok.
Thank you, Hitesh, for the introduction, and thanks for the opportunity to speak on your platform as well. So, can I go again?
Yes, please.
Yeah, okay. So, I will be speaking to you about nailing in subtrochanteric fractures. I've just titled it as reduction and fixation go hand in hand because that truly does. And I would focus predominantly on select problems and surgical tips and techniques that you can use to kind of nail successfully all kinds of subtrochanteric fractures that you might encounter in your practice. So these are my disclosures. None of them are probably relevant to this talk. So the learning objectives for this webinar would be to learn more about nailing of subtrochanteric fractures, focusing on how to understand the deforming forces that act in the proximal femur that you might have to handle when you try to nail these fractures. We will review the common displacement patterns in proximal femoral fractures in general and how they influence your surgical technique. We'll also understand the common problems that you might face during nailing of subtrochanteric fractures and how to overcome them. I'll tell you how to perform various minimally invasive and open reduction techniques that are often required when you deal with these fractures, and also select tips and tricks when it comes to nailing of these problem fractures. So first of all, the question is like, when there are so many difficulties, why choose nailing of a subtrochanteric fracture? Why should we do it? Why not do a different option? The first thing is the biomechanical advantage that a nail will give you. We all know that with regards to the lever arm and the forces acting upon the implant and also the fracture, the nail gives you a favorable loading pattern because it is centered along the medullary cavity. And so when you have a medial defect or a lateral wall failure, a nail being in an intramedullary location gives you an enormous advantage with regards to resisting the forces across the fracture. Nail also tends to be a more kind of a load sharing implant. So it tends to load the fracture if you allow them weight bearing and also during dynamic forces that act along the hip during range of motion. So being a load sharing implant definitely helps with regards to loading patterns across the fracture and also in healing, and also allows the patient to be active and uses hip joint during the course of fracture healing. And then when you choose a nail, it also helps you to do it in a minimally invasive manner. Though it may not be always possible, especially in subtroch fractures, this is very much a realistic option in select fractures, at least, where you can do a close reduction or even a minimally invasive percutaneous reduction so that you don't disturb the biology across the fracture too much. But is nailing a subtroch fracture easy? Definitely no, especially when it comes to an A3 fracture. Nailing it is definitely not easy. And if you don't nail it well, you are bound to fail most often, and failures can result in a lot of problems, especially loss of bone that might make future reconstructions definitely more difficult. And if you look at the literature, the amount of malunion, especially, like if I get the non-union things, like they will definitely fail. Even if they succeed, the amount of varus malunion you get in the proximal femur is tremendously high, around 33%. And these patients never do normal. They might still have a hip that is functioning, but they do have a lot of limitations. And even in this series, patients who had open reduction did better in terms of achieving a normal proximal femoral anatomy that you need to keep in mind as well. So how to prevent failures when you nail a subtroch fracture? You have to remember mechanics are the key. Though biology is important, when you think of treating a subtroch fracture, you need to restore mechanics. That is paramount. You have to remember union is not the only goal. You need to make the proximal femur look like a proximal femur so that it works seamlessly as it used to before the injury. Remember, reduction is paramount. Otherwise, most subtrochs will fail whether you nail or plate them. You need to restore length, alignment, and rotation, and make sure you do not leave your subtroch fracture distracted. This is bound to fail as well. So if you want to prevent failures, you need to restore the proximal femoral mechanics. So why is malalignment so common when you nail a subtroch fracture? Why does this happen? Most often it happens because you end up having a wrong entry point. This happens in turn because you have not got a good reduction. So when you nail a subtroch fracture, the main difficulty is the failure to control the small proximal fragment. That is what predisposes to all our problems. You can get a malreduction, which in turn will predispose you to a wrong entry point and then subsequent further malalignments. So if you look at if you look at the main points why nailing a subtroch fracture is difficult, one is the deforming forces. You know that the proximal femoral fragment in these fractures will be flexed, abducted, and externally rotated. And this will remain so even when you put the patient on traction most of the times. So you need to go in there, get this fracture fragment reduced before you can start your nailing procedure. Otherwise, more often than not, you will end up in problems because your nail will not reduce the fracture, which is mal-reduced. So without reduction, you do not get a good nail entry. So if you want to sort of reverse this pattern, it will never ever work. So it's always reduction first, and reduction can be very, very difficult of this short fragment. Second, as I said, is that the proximal fragment, which is bound to tremendous amount of deforming forces, is also short most of the times. And when it is short, the more difficult it makes for us to achieve a reduction. When you have a fracture, the subtrochanteric region that is slightly lower, it tends to behave more like a proximal femoral shaft fracture, and there the reduction is much more easier. But when you go higher, it is much, much more difficult because all these muscular forces, the abductors, external rotators, and the hip flexors tend to be concentrated on that small fragment, making reduction extremely, extremely difficult because it is multiplanar. So, and as I said, distraction will not reduce the fracture and you have to rely on different means. And will my nail reduce a fracture? No, because the proximal fragment is too short and sometimes the posterior segment of the proximal fragment is often much shorter. So you will not have an intramedullary reduction tool available and you need to rely on surface techniques. And the third problem is nailing process as such can malalign even a well-reduced fracture. So if you look at this example, it appears to be well reduced in terms of reduction on the AP view, but your nail entry can actually mal-reduce it. This happens because of mismatch in the angle between the nail and the neck shaft angle. And when that happens, you will predispose or shift the proximal fragment into varus, causing a mal-reduction. So a lot of things can happen over a nailing of a subtroch fracture that has to be handled. And last thing is, like, sometimes the anatomy itself might make it very difficult. That is the case with atypical fractures. If you look at this example, you can see that the proximal femur is not normal. You can see the medullary cavity is closed and you can see a lot of endosteal remodeling on that proximal femur. And if you are going to nail this, this can be really, really difficult. And often you can end up in malreductions like this. For atypical fractures, nailing is a great choice, but can be really difficult unless you follow certain principles and tricks. Otherwise, these can be really tough on you and also on the patient. So and from my preceding slides, you would have understood that with regards to successfully treating subtroch fractures, it is all about reduction. So unless you get a reduction, you will not be successful. And even when you get a reduction, you still have to complete nailing without losing reduction. That is a different task by itself. So I'll just take you through different case examples, focusing on reduction techniques predominantly. Of course, like my threshold to open a subtroch fracture is very, very less. But in spite of that, I think like a lot of times, if you can spend some time, most of these fractures are amenable for minimally invasive reduction techniques that you can perform successfully. So I'll take you through various reduction options that are possible and also tell you some tips and tricks how to do it. So if you look at this case example, this guy is an elderly gentleman who had a low velocity fall and had a spiral subtroch fracture that looks like this. So if you kind of put him on traction table, we do these fractures on traction table most of the times, but I often do it without traction. So this is how it looks on traction. This looks to be reasonably acceptable on AP view, but is this really right to go again with the nailing? I don't think so, because if you look at the AP view carefully, if you focus on the greater trochanter, you can see that the greater troch is definitely not appearing as a point. This indicates that the greater troch or the proximal fragment is still externally rotated and you do not have an ideal entry point. So you need to correct it so that you can get a more medial and correct entry point. And if you look at the lateral, it looks okay. Sorry, it looks off. I'm not able to see it on the, because the lateral looks off. So definitely on both views, it is not ready to start your nailing process. So what do? We can go ahead and do minimally invasive reduction techniques to get your reduction right. So this is an interesting technique, a very simple one as well from Korea. These guys describe a simple surface technique where you can correct external rotation of the proximal fragment. So what these guys do is like they use an artery clamp, go through the vastus, and then slide the artery clamp over the proximal femoral fragment anteriorly, and then lever it into an internal rotation kind of thing. So what happens is like the artery clamp uses the muscle attachments onto the lateral side to bring in internal rotation of the proximal fragment that is externally rotated. So this is a very easy technique to do, and good thing is this does not interfere with your nailing process. You can also do a K-wire or a shunt spin into the proximal fragment to control that. But the problem is you have to really place them correctly so that your nailing process goes unhindered. But this happens on the surface, so it doesn't interfere with the nailing process at all. And as you can see on the left images from their own article, you can see that once your artery clamp is in place, you can see that the greater troch now appears in profile as a point, and you can go slightly medial to that and get your right entry point and start nailing this one. So this is a great trick as well, and I use it all the time. And a lot of times this one helps me to control the flexion deformity as well, not just the internal rotation. So sometimes this will be the only reduction tool that I will use in a subtroch fracture. So this is a great tool to use actually. It takes no time and no fluoroscopy is required. So you got your AP reduction right, but your lateral still does not look good. So at this point, you can see the artery clamp lying over the proximal fragment, but here my flexion is not still corrected. So at this point, a lot of us will think like, can I go ahead and try to nail it along the axis of the proximal segment and then get into the distal segment? I think you should resist, because as you can see, the proximal segment posteriorly is extremely short and your nail will never work effectively as a joystick here. So what next? Our go-to would be to use multiple clamps. You can use pointed clamps that you can place them in both lateral and AP planes. And you can also use the serrated bone clamps as well. And often you require a multiple of tools. Our go-to tools would be the pointed clamps, the bone hooks, and the ball spike pushers, along with the artery clamp anteriorly. And most often with the combination of these tools, you will be able to kind of reduce your fracture, as we have shown here in one of our examples. And then once that is done, you can go ahead and nail your fracture, which will go on to heal in an anatomical manner. So this is an example of some kind of surface reduction tools that you can use in a subtroch fracture. So if you look at this again, for example, just to highlight the utility of the anterior artery clamp. young male with a high velocity injury. He's got a kind of a low subtroch with significant amounts of comminution. And if you look at the CM images, this is how it looks under a little bit of traction. As you can see, the AP looks kind of okay, but it is still external rotated, as you can see by the lesser trough profile. And the lateral looks completely off. So again, the same technique. We go again and use an artery clamp. You can see that we are bringing the internal rotation into the proximal fragment now. And you can see on the lateral view also, I'm getting my proximal fragment in line with the main distal shaft fragment. So once I've got that, I can go again and get my nail entry done carefully under fluoroscopy, and gradually I can reduce this fracture absolutely closed and get my nail inside, and that is how it looks like at the end of the procedure. So sometimes, as I said, this would be the only reduction tool that I would require to reduce a subtroch fracture, which is quite easy. So what other clamps that you can use? You can use a lot of other clamps as well. So this was a 37 male with a kind of a transtrochanteric fracture. As you can see, he's got a combination on the lateral side as well. And this is not going to reduce interaction. And like without reducing this one, you will never get your nail entry right. So if you look at this, this is what it looks like. If I'm going to kind of go there with this picture and start nailing it, there is a high possibility that I might go through the fracture and compromise or blow out the lateral wall. So these fractures require reduction, and you can reduce them almost anatomically with a clamp so that you will get your ideal entry point and also preserve the lateral wall. So go again, a couple of pointed clamps on the lateral wall, hold them in place and then nail them. They do absolutely well. And in young patients, this is the kind of nail that you will require. You don't require the high profile nails like the proximal femoral nails that you use in the elderly patients, because like they will take up a lot of bone and can make the procedure much more difficult. So what you require in these fractures in young patients is the recon type of nails, which have a much lower profile. So this is another male, a 44-year-old with a comminuted A3 type fracture. Again, as you can see, there you have a fracture on the lateral wall as well, which appears separate fragment. So again, if you look at it on the AP, it looks reasonable, but on the lateral plane, you have a malreduction. Again, like here we go again, put a small incision and then the serrated clamp goes there, reduce it, clamp it anatomically, and then go again and nail it. So you can use a different varieties of clamps. So depending on what kind of a fracture pattern we have. So what about wires and cables? They are great tool as well in select subtroch fractures. We use them in spiral subtroch fractures and also in fact some fractures which are long oblique to kind of like hold them reduced when we nail our fractures. So they can be used as a biologically effective tool. You do not have to have concerns about it in terms of affecting the blood supply of the periosteum. Several experiments have shown them they are effective and they are biological as well. There are percutaneous tools as well, which you can use to pass them elegantly and hold your fracture reduced till you nail it. So this is one of the case, like the same case like which we have shown here, a single wire and then nailed effectively, which went on to yield uneventfully at 3 months. This was another case in an elderly male, the comminuted subtroch. And as you can see there, you can see a butterfly combination on the medial side and all the typical deformities that you will encounter in a subtroch fracture. And this is what it looks like. So here I probably I could have gone again without wiring this as well, because I don't think that fragment actually helps in kind of stabilizing it. But so again, the same technique, you can see the artery clamp coming in and then my entry, and I felt my entry, my reamer was going into the medial side persistently, because that is the pathway of least resistance. Your nail kind of tends to go in medial side through the comminution. So I had to sort of wire this on so that I can get my nail centered in the medullary cavity and not getting the proximal fragment into varus. So just a single wire to hold that comminuted butterfly fragment, which is part of both the proximal and the distal segments. So that is one problem. So once we have done that, we got your nail in place, and then it looks pretty well reduced in both planes. So another case, obese patient with a BMI of 37, a similar spiral combination, And this was considering his obesity. We did it in lateral position. Lateral position does make it certain things easier, especially the entry and certain amount of reduction as well, but it makes a lot of other things difficult too, like access to fluoroscopy, and sometimes like even the entire nailing process can be a little bit difficult to do. So like I prefer to do them in supine position, but lateral position can be useful in patients, especially who are obese, and I also use them in revisions as well. So in this case, like we used 2 wires. One was to reduce the lateral wall to the proximal fragment in order to contain the nail. So if you have a lateral wall fracture and if you want to keep that, and if you want to use a nail, you have to make sure the nail is contained. So if you have a lateral wall fracture that is undisplaced, attached to soft tissues either well, then you do not have to worry about it as long as your nail is contained. But if you have a lateral wall that is kind of floating, either drifting posteriorly or migrating superiorly, then those lateral walls should be put back in place and stabilized so that your nail will be contained in the proximal segment. And then another wire to hold and reduce the main fracture line. And then it goes on to be fixed and healed well at 3 months rather. So what about other reduction techniques? Joysticks are a great tool as well. I use them quite a lot, especially in fractures that are short, oblique, and transverse, where I can't use clamps very effectively. So if you're trying to kind of reduce this fracture in a closed or a minimally invasive manner, joysticks are a great way to do it. So you can use joysticks in both planes, in either from lateral to medial to control abduction and also rotation. And also in the flexion extension, deformity can be controlled by passing a joystick in the anterior-posterior plane. So here, if you can look at it, there's a joystick on the medial-lateral plane to control abduction. And once, if you position them carefully, much anteriorly, you can go again, and the nailing can be done without any hindrance. Here, a few more reduction techniques have been used to control and center the nail in the proximal fragment with like a posterior blocking pin as well. And once done, this can go on to heal without any problems. So another case to illustrate an anterior-posterior joystick, if you can look at this again, the proximal segment, the fracture line is pretty much a short oblique or a transverse with kind of a combination in the medial side. So this is what it looks like on the AP and lateral views. You can see the AP looks pretty much aligned, but the lateral, you can see there is a flexion deformity. So here I don't need a joystick from the medial lateral plane because that looks all right. But the flexion extension deformity, if you want to correct it, joystick is a great tool. So what I typically do is put a joystick medially into the lesser troch region, which got great hold, and you can do it in a safe manner by using a sleeve. And once it is in place, you can kind of use a joystick to correct the flexion deformity and go again with your nailing, because this wire is in the region of the lesser troch, well outside the medullary cavity, so it doesn't come into the picture when you start nailing your fracture. So this is what it looks like. You can see the location of the joystick over there on the medial side. So once you've corrected the deformity, you can go again, get your nail, and this is what it looks like. So joystick placement, if you want to use them, choose your fracture. It works well in transverse and short oblique fractures. And depending on the deforming force, you may choose to use 1 or 2 joysticks. Mediolateral to control abduction and rotation, and in the AP plane to control flexion. So collinear clamp is also another great tool if you want to use it. I prefer them for certain spiral fractures and also some long oblique fractures. So you can go again, if you have access to a collinear clamp, the advantage is like it can be used through a very small incision. It can, whereas like sometimes you are going to use a pointed clamp or even the serrated bone clamp, sometimes it can be difficult to place them through a small incision, whereas the collinear clamp can be placed very effectively through a small incision. So it does well as well. It does work as well. So to me, the most difficult fractures to reduce in the subtroch are the transverse fractures, because it's difficult to clamp or wire them. So like it often requires open reduction in my hands. Joysticks is one tool that I try to use, but sometimes if I'm not successful, I will have a very low threshold to go again, open and clamp it on both sides, reduce, and then go again with my reduction, with my nailing. So transverse fractures can be really difficult to reduce. So you should not hesitate to resort to open reduction. So a few other reduction tips and tricks, like this is an elderly female, the A3 kind of fracture. As you can see, you have a kind of a transproc fracture and also a fracture in the coronal plane that goes high up into the entry point of the nail. And there is a tremendous amount of osteoporosis as well. So if you look at the AP and the lateral CM images, you have medial translation in the AP plane and a flexed proximal femur in the lateral plane. So push-pull techniques again are a great tool. Okay, like you can use a ball spike pusher, or different kind of pushers can be used, and you can also use a bone who kind of adjust these translatory deformities so that you can reduce and then nail them successfully. So here, if you look at one pusher controls the medial translation and the other one in the different plane controls the reduction in the sagittal plane. So once you got your reduction, you can go again. This can be done using very minimal small incisions. So you can go again and then nail them anatomically and they will do well. Another very similar case with a comminuted reverse oblique pattern with a broken lateral wall. Again, an elderly patient, an osteoporotic with a low velocity fall. Again, in these cases, we prefer to use high profile nails, as you saw in the last case as well. But in younger patients, we tend to use recon nails most of the time. So again, if you look at it, you have a translated deformity in the coronal plane. A bone hook works great as well. It's a very simple instrument that's available with everybody. You can go again, use a bone hook to correct it, and then simultaneously, if required, you can use a ball spike pusher as well in the sagittal plane, and then control your reductions, go again, start your entry, and then ream it concentrically, and then go again and put in your nail in. And you can see it heals well at 6 weeks pretty much. So so these are the kind of reduction techniques you guys can think of when you want to minimally reduce your subtroch fracture using minimally invasive techniques. So these are different kinds of tools, but you cannot say one tool works for all fractures. Most often you may have to rely on a combination of tools. So, but if you can sort of read and plan your fracture carefully and spend some time on it on table, most of these fractures can be reduced without a formal reduction, open reduction, supine on a fracture or a regular table. So if you look at this case, like a 63-year-old male who had a low velocity fall, obese, you can see the spiral fracture pattern. This is how it looks on fracture table. Looks pretty good reduction on both planes. But once you start nailing it, it kind of drifts into it. This is because the entry point is wrong here, as you can see. So even if you have a good reduction, unless you have your entry point right, and you use a nail of an appropriate proximal angle, you can still drift the fracture into varus. So reduction is one thing, and then nailing is the other. So you have to kind of make this go hand in hand, and you have to understand that if your nailing technique is not proper, you can still end up with a mal-reduced fracture. So what are the hurdles that kind of doesn't allow you to get a good entry for nailing a subtroch fracture? So if you look at this case, you can see the iliac flare coming up and not allowing the surgeon to get a straight shot at the femur. So this can happen in a lot of muscular patients and also obese patients, especially if you are operating them supine. So you can have iliac impingement, which might not allow you to get a straight shot at the femur using an ideal entry point, which will be a few millimeters medial to the tip of the greater trochanter. The gluteal muscles also doesn't help your cause. So especially in a very muscular patients and obese patients, they can also push your guide wire more and more laterally and not allowing you to get a straight shot at your femur. So the thing is this iliac impingement and the influence of the gluteal musculature is real, and you have to overcome this. One way is to start as high as possible so that the skin entry has to be as high as possible so that you get your entry point absolutely in line with your femoral shaft. So sometimes, especially in very obese patients, your entry point on skin can be really, really high. So before you commit an incision, make sure you get your entry point trajectory right, and then start extending your incision from proximal to distal. Sometimes this entry point can be as high as the iliac at the ASIS. So what are the tips to get a good entry? So if you are doing it in supine, make sure you have some kind of hip flexion so that the entry point is translated posteriorly, where your iliac crest, the flare will not interfere and make it difficult. So have some kind of hip flexion. If you are doing it on a fracture table or a regular table, have some kind of hip flexion, which will definitely help a lot. And another way is to do it in lateral position, as I told you. So as I said earlier, lateral position definitely gives you a great access to the entry point without any kind of hurdle. It's absolutely easy, but it can make a lot of other things difficult if you are not really well versed how to do it. So, but this is one way of doing it as well. So the second thing is like, we appreciate the importance of medial reaming when you nail a proximal femoral fracture, especially the osteoporotic ones. So if you look at this lateral image, for example, the trajectory, though not accurate, I would probably prefer it to go a little bit more medial, but it is not really bad. If this is a shaft fracture, this will work very well. But if you look at when the nail goes in, the fracture still drifts into varus. That is because, like, when you start reaming your fracture, even though your entry point may be right, especially if you are dealing with an osteoporotic bone, your reamer will tend to core out the more weaker lateral bone unless you control it. So that will make your nail or the reamer fall into the lateral side, and then that will create a mismatch between the nail angle and the proximal femoral angle, which will again predispose the fracture to drift into varus. So again, reaming your bone on the medial side and preserving the lateral bone is important when you ream a fracture, so that you can nail them successfully. So once you have corrected that, there are a lot of ways to do it. Angle plates, retractors, artery clamps. A lot of things have been described, but none of them work reliably that you can use it for all fractures. So it depends. So make sure you have your sleeve in. If you are finding the medial cortical bone, you can also use a wrong word to kind of nibble the medial cortical bone, so that you can ream that out before you can pass your nail in. So make sure you preserve the lateral bone and do not allow your reamer to fall into the lateral side, removing or coring out the entire lateral bone. So if it does happen, your fracture, make sure, trust me, it will definitely drift into varus, and you have to avoid that. So, and this is one way of getting a perfect nail entry and a perfect nail trajectory, and I like this a lot. That is like reaming and creating an entry point through the fracture site in a subtroch fracture. So this is how we do it, and we do it in quite a few fractures. Like, we started doing it in lateral position for our revision cases, where we open it up and then create entry point, a fresh entry point, because these fractures have been already nailed. So I want to avoid that entry point, and to go more medially, which can be really difficult if I come from proximal. So we started using this in some revision fractures, where, since when you go through the fracture site, you are actually going from lateral to medial, compared to when you come from proximal, where you are always struggling to go to the medial side. So this is a very easy way of doing it. And now we do it in supine position as well. So it is quite easy. You don't need a reduced fracture to do it. So you make use of the fracture displacement, go through the fracture site, pass your guide pin. It will exit through the piriformis fossa or more medially. So your entry point is already determined, and you are not going to go wrong here. And once you have got your entry point, confirm on fluoroscopy, and then use your channel reamer. And once you have got it, you can reduce your fracture and then create a proximal incision and put your guide wire in. So you can do it in supine as well. So we use it, as I said, in two indications, like atypical fractures and revisions, but now we do it in fresh fractures as well, where we resort to open reduction. It saves you a lot of time, and we published this recently as well in injury. And these are some of the advantages. As you can see in these images, when you go from distal, I can sort of like it wherever I want. But when you are coming from proximal, even when you reduce a fracture and hold it anatomically, there are still hurdles, like the iliac flare impinging on your drill. So you will still have hurdles in getting your entry point right, and not just the entry point, your trajectory has to be right as well. A lot of times in proximal femoral fractures, like you will have a medial comminution and you will tend to fall onto the medial side. So when you do it from a retrograde manner, you go from lateral to medial, from distal to proximal. So it's really easy to control that. And so this is how we do it in atypical fractures. So in atypical fractures, a couple of things are very important. You need to have a well medial entry point. And two, there is a lot of endosteal remodeling on the lateral side. And unless you remove it, your dreamer will kind of tend to fall medially, because that is a weaker bone, and then remove all the medial bone, which will again make the fracture go into varus. So as you can see in this fracture, like here, the medullary cavity was completely sealed on both sides. So again, like we open it up, create a medullary cavity, and then take a retrograde entry point, and which sort of it gets us into the piriformis fossa, and then we can go again and nail this anatomically. Since the nail is in the in the axial medullary cavity, you will not create a malreduction. So another case of an atypical fracture here, very similar principles as you can see here. Here, like in spite of adequate endosteal reaming, we still had a problem. So a lateral plate was used to control that, and then nail it successfully, which goes on to heal. So to summarize, if you want to reduce and nail a subtrochanteric fracture successfully, three things are important. One, you need to achieve an anatomical fracture reduction or a functional fracture reduction, whereby I mean you restore length, alignment, and rotation, and adequate bony contact. This has to be done biologically. Doesn't mean that this has to be done closed or using minimal access. You can also do an open reduction and yet be biological. So ultimately, as I said in the first slide, mechanics are the key. You need to respect biology, but mechanics are the priority. Second, you need to have a good nail entry. To have a good nail entry, you need to have a good fracture reduction. Often, the appropriate nail entry for a subtroch fracture would be slightly more medial to the tip of the troch. It's somewhere around 3 to 5 millimeters medial to the tip of the troch, and that is where you need to enter. And you preferably use an angle, use a nail that does not have a huge mediolateral angle proximally. Most of the current generation nails will have around 4 to 5 degree angle to allow ease of access, and you can get them well medial to the tip of the troch. You don't have to enter the tip of the troch, where you will most often end up malreducing. Third, once you've got your fracture reduction and nail entry right, you have to make sure you nail it using appropriate techniques, so that you avoid loss of reduction. So to avoid loss of reduction, as I said, nail entry is important. You need to remount the medial bone. And if you are dealing with atypical fractures, you have to be careful about the endosteal beaking, and you need to remove that as well. So unless like you are careful about the nailing process, you can malreduce a fracture, which has been previously well reduced during the nailing process. Thank you.
Thank you, Sunil, for that brilliant talk of yours. And you've covered almost everything about technical tips. And I remember the good old days when we started doing the gamma nail and the Cyrus nail, and how difficult it was to get people convinced that the intramedullary nailing is going to be the future. Sunil, a couple of questions. Now, one is regarding the technical,
like, yes. Yeah.
One is regarding the technical tip, where you showed that particular paper from South Korea, where they've used an artery forceps.
I lost you, mate.
Sunil, can you hear me?
Yes. Yeah, I can hear you now.
Yeah. So the question is, see, you've shown a paper where they've used an artery forceps to do that internal rotation moment, right? Do you think a Homan spike would be a better thing? Do you think artery forceps could do that internal rotation? Because it's very strong muscular, right?
Yes.
So do you think a Homan spike would be a better choice?
Yeah, possible. You can use it. Okay. You can use it. Probably something with a. They have used an artery clamp. What I use is a cocker clamp. I use a cocker with a long handle most of the times, and I tend to sort of like use it as posteriorly as possible. Start so that. So and then like go again. As I said, like as you said, a woman shouldn't be a bad choice. It's just an instrument like anything that goes under the vastus to make use of the vastus gluteal attachment relationship to bring in internal rotation.
Thank you, Sunil, for that. And the other question is, see, what has happened in last 10 years is not subtrochanteric. If you talk about intertrochanteric as well, everyone is going towards this particular implant called as PFN A2, right? Everyone is obsessed about putting a PFN A2. Okay. And do you think there are significant complications with a PFN A2, like a femoral head perforation, an iatrogenic lateral wall perforation? And do you think a PFN A2 has more complications compared to the regular PFN? What does the AO dictate?
Yeah. So I think like a few things like if you mean by a regular PFN, if you mean the two screws that AO sometime introduced, I think that is probably in my opinion, like we never had that AO device in India actually. Like we had only the indigenous made two screw PFNs, which came in 8 and 6 mm screws. But if you look at the AO PFN as such, like it has 11, the weight bearing screw is actually 11 mm. We never added air actually. But so when you have an 8 mm and 6 mm screw, where 6 mm screw is an anti-rotation screw, anti-rotation pin, where only the 8 mm screw is the weight bearing screw. I thought that was not a great construct to deal with the geriatric subtroch fracture or intertroch fracture. So I'm not when you say regular PFN, that is not my go-to device. But I think gamma, okay, or any screw-based device, okay. I think when the blade came, it was thought that it will give you superior outcomes compared to a screw. But I really don't think so because like we used it for 5 years continuous, and we published our results in 2013. I think we reported a 20% complication rate of the PFN A2. So and if you look at subsequent literature after that, and there are quite a few papers, impressive ones, that report that the number of complications are probably more with blades. And also the blades do not give you superior outcomes even in osteoporotic fractures. I don't think they are better than a screw. So I'm quite convinced with regards to that. So right now, like the thing is, like I use blades. I don't use the PFNA, but I use the TFNA, the more recent one. But I agree with you. But with the TFNA, I think like there are certain design advantages compared to a PFNA, definitely. But right now, like my go-to device would still be a screw-based implant for the osteoporotic subtroch fracture. I use a TFNA in select situations.
Now, what is the difference between a PFN and a trochanteric fixation like the TFN? What is the design difference?
Yeah, so if you look at the lateral profile of the TFNA is much lower, so that it allows you to put it inside easier, and also lessens the possibility that you might break the lateral wall. One, and then like there is a possibility to compress and then hold your fixation. Okay, that was not possible. I think like if you look at the concept with the integrated lag screws from Smith and Nephew, okay, like the concept is we always used to believe that these fractures should be allowed to slide and collapse during the process of fracture healing. That is how we have been taught. But I think like there is good enough evidence right now that you can compress these fractures on table under vision in a very controlled manner, rather than relying on dynamic collapse that happens during fracture healing, which may not be under your control at all. So once you have done that, got your fractures fixed in a manner that you want, you stop everything. Don't allow any more sliding. So those kind of concepts have shown initial success, initial good success as well. So right now, the TFNA design allows you to do that. So where you can kind of completely lock it so that you don't allow your fracture to collapse, or if you want to allow it to collapse, still you can do it. So you have the option of doing it both. And that is the current kind of design concepts most people believe in. So I think like that has benefits. And you might remember we published our results as well in the Intertan, where we compared both, and not in terms of major complications, but there were certain advantages with the integrated lag screws compared to a blade.
Thank you, Sunil, for that. Just one last question before we wind up the session. Now, are there situations where you don't want to use an intramedullary nail? For example, is there a contraindication and where you would prefer a locking plate? Okay, a proximal femoral locking plate.
Yeah. So for me, proximal, if you ask me when I use a plate, yes, I use a plate. The most common indication for me to plate proximal femoral fracture will come in a revision situation where I use a blade plate, sometimes alone or sometimes in addition with an anterior blade. But in a primary situation, I very rarely use blade plates. Proximal femoral plates, yes, I have used it but very few times. My indication for using a plate in a primary situation is like when I have a lateral wall that is completely floating, where it has no kind of relationship with the proximal fragment. So in these cases, like my options are go again, reduce the lateral wall to the proximal and the distal fragment, and then go again with my stabilization. So in this scenario, there are a few instances where I have gone again with a proximal femoral lock plate, because here, unless you reduce it, I don't plate my lateral wall in all fractures as some people do it. So there are some proponents who say whenever a lateral wall is fractured, they should plate it as well. And there are some innovative designs where they have a nail and a plate going together as well. So, but we don't do it that way. But whenever my lateral wall is completely floating, in those instances, I go again, do an open reduction, and from there on, it's either a proximal femoral plate or a nail with an additional lateral plate, a low profile one.
Thank you, Sunil. Sunil, I think that's all the questions that we have for this session. Fantastic lecture. And I'm sure this lecture is going to benefit a lot of people all over the world.
Thank you so much, mate. Thank you so much. Thanks for the
invitation.
Thank you so much
again. For joining.